our team here. So Colleen and Katie and Anna are on our ECHO team and have helped develop the curriculum. And then Tina is internal to our organization. So good to see you, Tina, as well. And then welcome to Rick and April, and hopefully some more CPS folks will be joining. So this is meant to be interactive. I super appreciate you guys turning on your cameras. So I'll present on information that I know you work with lots of pregnant patients in CPS or work with them postpartum at any rate. And so that's what we're going to talk about today is treatment of substance use disorders in pregnancy. And then we'll have a case afterwards. And I also welcome you guys, even though you didn't present or submit anything, talking about any cases that you're currently dealing with or in general situations like X, Y, and Z that you often deal with. We're happy to talk about those. So I will share my screen. Okay, sorry, I have too many things pulled up here. All right, everybody can see that. Does that look right? Okay. So at Chestnut Ridge Center, we actually have a pregnancy clinic specifically for pregnant women with substance use disorders. And what we see mostly is pregnant women with opioid use disorders. So we do have a medication component to this clinic, but we also see women who have other kinds of substance use disorders as well. And we started that in 2011 because we found that for a lot of pregnant women who were being seen in our regular clinic, because we have a group-based treatment program, they were super quiet and very uncomfortable talking. And a lot of what they wanted to talk about was pregnancy related. And they didn't feel talking about that in a mixed gender group. So we created this clinic, which I'll talk about at the end, but I'm going to kind of do an overview. So just a reminder that addiction is considered to be a disease and a chronic, treatable, preventable one. So chronic being after someone has, X number of days of abstinence, it does not mean their risk goes away. They're always at risk for recurrence and becoming symptomatic again. When we think about disease, we think about what organ does it affect? And for addiction, the primary organ that it affects is really the brain. And we know this from kind of 20 years of MRI studies, is that people's brains are temporarily and sometimes permanently changed as a result of chronic use of substances. And treatment is effective at helping reverse some of those changes. Some of them are structural, some of them are really chemical. And so treatment can help, both medication as well as psychosocial treatment. So just kind of in terms of what we see. So when I think about this, whenever I have a pregnant woman coming to me with a substance use disorder, I think she very likely has a trauma history. So it's kind of 3 out of 4 women who have significant substance use disorders have a trauma history. So 75% have physical or sexual abuse, and those rates are higher among women who use substances intravenously. So very high rates. And when you look at that, very high rates of incest. So we know that in terms of the continuum of severity of trauma, incest is the kind of on the extreme severity because of the kind of power and boundary violations that occur when incest happens. And those rates are extremely high for women with substance use disorders. So in terms of outcomes, we want women to come to treatment. Obviously, not everybody is ready at the moment we think they should go. And so how to help people get ready is one of the things we're going to talk about. But we know that when women come into treatment for substance use disorder, it decreases their active substance use. It increases their attendance at prenatal care appointments. And sometimes we can help them get into prenatal care if they haven't already gone, because they often are afraid to seek prenatal care for fear of, if they have other children, they show up and admit they have a substance use problem, that their other children will be removed immediately. It reduces overdose deaths. It improves neonatal outcomes, so babies do better. And then all kinds of co-occurring infections rates are decreased. So HIV, I don't know if people know, but West Virginia currently has an HIV outbreak larger than anywhere in the United States, and it's centered around kind of the southern West Virginia in the Huntington area, which is often not talked about, but we currently have the biggest HIV outbreak in the country. And hepatitis C, so we have the second highest rates of hepatitis C in the country. And both HIV, these increases of HIV and hep C are really being driven by intravenous use. And so catching those early, hep C we can now cure, as many of you guys know. Like, it's one of those diseases in my lifetime that has gone from treatable but not curable to curable, which is like the most amazing thing. And it is very easy to cure. It's between 8 and 12 weeks of medication. And there's not a lot of side effects to the medication, which is wonderful. So we try and get patients hooked up to treatment for that if they come into treatment for substance use disorders. And then infective endocarditis, which is highly lethal and very expensive to treat in the hospital setting. So coming into treatment can help with all of those and prevention of all of those. So how significant is the problem? I'm sure you guys at CPS know it's very significant, and I can't remember, the rates differ a little bit, but I think you guys told me about 90% of the individuals that you see are being referred to Child Protective Services because of substance-related problems that are occurring with, inability to care for kids and keep kids safe. So this is high on your list of what you're trying to address when you work with families, I'm sure. So younger women are a little bit more likely to have illicit drug use in the last month, and this is from the National Survey of Drug Use and Health. And older women slightly less. One of the things we probably do not pay a lot of attention to, although in 2010 there was a study that really highlighted the high rates of alcohol use among our pregnant women. This is much higher than in the national average. This is almost like 1 in 5 are using either drugs or alcohol, and the rates of alcohol were higher than in other states. So I was actually just talking on Monday with some colleagues, and we don't even screen for alcohol because it's legal. So, but in fact, alcohol is the most dangerous substance to use during pregnancy in terms of effects on the baby. And so we need to make sure we're asking about that and talking about that both in treatment and when we're screening folks. So 1 million babies are born nationally exposed to substances, and about 4,000 a year in West Virginia, but treatment absolutely helps. So the most common substances used among pregnant women are still tobacco and marijuana. And I just saw a recent article come out. There's been a minimization of the negative impact on the developing fetus in terms of marijuana and THC products, but it's real and it is not good for babies. And so we need to work on our messaging. We've gotten much better at communicating the risks of using tobacco during pregnancy, although West Virginia has very high rates of tobacco use among the general population and high rates among pregnant women as well. We, in our treatment program, consistently try and offer nicotine replacement, so at least people are moving away from tobacco products, which are pretty toxic. So I like to think of this population as having a lot of strengths. They are often highly motivated. So the number of times I've heard women say, if I were not pregnant, I would not be seeking treatment. So they wouldn't do it for themselves, but they want to do it for their child. I hear that over and over again. So we have this window of opportunity to really get people into treatment and into recovery because their level of motivation is higher when pregnant. And they can kind of have some of that ambivalence resolved during pregnancy. It also means that after they deliver, they're at very high risk for relapse because they are no longer carrying the baby inside of them, and they feel like, oh, the risk to the child is not as great. They tend to be a little bit younger, so maybe a shorter progression of their addiction. They often have family support. Families rally around pregnant women as it being an exciting time. Not always, but sometimes. And they're often like hopeful about the future. Like this really is a life-changing event for most women, including women with substance use disorders, and they see it as an opportunity to really do something different. And that can lead to high levels of willingness. So some of the challenges is often people are experiencing or have experienced or are at risk for experiencing intimate partner violence. So there's domestic violence in the home. They don't feel safe, but they do not have the resources to leave. So again, one of the things we can help people with in treatment, and I know CPS can help people with as well. Pregnant women with substance use disorders have high levels of guilt and shame. And so even if they are looking angry and resistant, they are no doubt experiencing guilt and shame, even if that's not really being expressed. We can assume it's like under the surface. And oftentimes women don't realize they're pregnant, especially if they're using substances and very underweight because they're not having regular menstrual cycles. And so they've been using during their first half of their pregnancy because they don't sort of realize until, month 5 or 6 that they're pregnant. And again, that contributes to the guilt and shame and the fear about what they've done with their substance use in terms of exposing the baby. There's childcare issues, transportation issues that can be barriers to treatment or barriers to compliance with CPS requirements, and then employment issues and financial issues too, because often folks don't have stable employment. So medical complications with pregnant women with substance use disorders are high if they continue to use, and we talk about this in treatment with people on a regular basis. And then very high levels of stigma by their own family members, by the community and healthcare providers. Again, one of the reasons we moved pregnant women out of the mixed gender groups is they felt stigmatized by their own peers who were in recovery for substance use disorders. So if they were to report a slip or a recurrence of use, they felt judged by their peers, like, well, you're pregnant, you can't even stop using substances. And so they were very reluctant to get honest. And we see a real change when we have begun to treat women in all women's groups with other women who are pregnant. And we know stigma is a big barrier to seeking treatment, so we want to reduce that stigma wherever we are able. Post-delivery challenges is that increase of relapse, increase dropping out of treatment. It's like I stayed in treatment to get through this and now I don't need it anymore, when in fact what we see is an increase in recurrence of use and overdose and death in that postpartum period. Women have increased anxiety and depression often. So postpartum depression, they're at risk for that for up to a year. Sometimes we think of that 3-month window. Oh, if you don't have any onset of depression in that 3-month window, you're in the clear, when in fact the risk extends to the entire year postpartum. There's some negative family interactions. There's often, even though it's supposed to be a wonderful time, it's often really, really stressful to have a baby. And so being on the lookout for that is important. That stress can sometimes be caused by the baby having neonatal abstinence syndrome if they were exposed to substances in utero, and that can be a factor with medication-assisted treatment as well. Neonatal abstinence syndrome is really a catch-all phrase for exposure to any substance. So exposure to opioids, including any medication like methadone or buprenorphine, is very treatable, and typically effects are not long lasting if mom remains in treatment and is able to remain stable. So CPS involvement and possible child removal is a challenge. And we try and prepare our patients for that, saying CPS will contact you. They will show up at the hospital. And the longer you have in sobriety prior to giving birth is going to be the better outcome. And that guilt and shame, again, that they may or may not be expressing directly, but we know is there. So just a little bit, because I threw in this map because I know we were having people from all over the state. So the highest rates of neonatal abstinence syndrome are in region 1, which is the Northern Panhandle. And then you can kind of see where you guys fall. So in our general region, which is kind of Mon, Marion, Preston, Taylor, Harrison, Barber, we are region 4. And so we are kind of second highest incidence. This is a little bit misleading because reporting is not always consistent. So birthing centers and hospitals, some are really good about reporting and diagnosing and some are not. So this obviously hinges on whether or not people are reporting and diagnosing. And you can also see with the bar graph that the prevalence is higher among Medicaid patients. So I just can't stress enough what we think of as the 4th trimester now, which is that postpartum period up to a year, is a very high risk for recurrence of use, overdose, and overdose death. So you can see this is really tiny, but in general, like the bar graphs show that the lowest incidence in terms of mortality as a result of overdose is in that 2nd and 3rd trimester, and then it increases even higher than it was earlier on in the pregnancy, even before they were pregnant. So it goes up higher than it was before they were pregnant. So something to pay attention to. Sometimes the stressor of having child removal will also put people at high risk for recurrence and overdose. So just wanted to focus a little bit on treatment. So treatment options during pregnancy are inpatient detoxification. So there are a few providers who are doing this around the state. This is not recommended by ASAM, which is the addiction medicine group, or by the obstetric group. So the American Academy of Obstetrics and Gynecology do not recommend detoxification. It's not that you can't keep a baby safe and detoxify mom or have her safely come off medicine. It is that after that occurs, the relapse rates, if you sort of just send the person out into the world, are very, very high. And so people don't always follow up with treatment post-detox. And if they do not follow up with treatment, the relapse rates are 90+%. And so if they have an opioid use disorder, we have very effective medications for opioid use disorder that have been shown to really reduce relapse and overdose. Residential treatment is certainly an option. We have some residential treatment specific to this population around the state, which is wonderful. I think treating women together in a cohort or who are experiencing pregnancy is always ideal. Lots of stuff for them to talk about and work on and share. Outpatient therapy is obviously another level of care that can be pursued, and the medications for opioid use disorder being methadone, Suboxone, and Subutex. So just a little bit about those medications. Methadone is a full opioid agonist, which means it has no ceiling effect. So if you take more and more and more, it can cause intoxication. Buprenorphine has a ceiling effect. So taking more of that medication eventually will make people feel sick as opposed to be intoxicated. Although if somebody is opioid naive and has no tolerance to opioids, it can produce kind of an effect where people feel altered. So sometimes there's some confusion about Subutex versus Suboxone. They are both, the medication in those are both buprenorphine, which are partial agonists. And then the Suboxone or Zubsolv, it comes in some different formulations, is the combination product of the naloxone and the buprenorphine. There has been enough research now to really show that, and I'll just kind of show lots of research looking at buprenorphine alone versus buprenorphine plus naloxone, the combination product, and it has found to be safe in pregnancy. So these are just a few studies that have been done. So no negative effects for baby. Initially, there was concern about negative effects because of a rat study that was done like 20 years ago, where they gave rats a lot of naloxone, and it was problematic. But in these studies over the last 10 years, there's really been no negative effects. And the risk for misuse of the product that does not have naloxone is increased, which is why in 2015 at our clinic, we started prescribing the combination product only, unless there is some, some allergy, which is very rare. So benefits versus risks, it's not whenever anybody takes a medication, especially when they're pregnant, there is always a risk. So the benefits are in terms of preventing withdrawal, blocking euphoric effects of other opioids, enhancing retention and treatment, reducing relapse. You can see all those positive effects. And obviously the risks that are of great concern are neonatal abstinence syndrome, pain management issues at the time of delivery, which can absolutely be negotiated in collaboration with the OB providers. There is a risk of abuse and diversion because we know there's a street value for this medication. And then families can be very anti-MOUD and see it as trading one drug for another. So we try and do some education around that wherever possible. Often people have questions about breastfeeding. Breastfeeding is encouraged for women with substance use disorders as long as they are not using any other substances. They are allowed to breastfeed on medication. So that includes methadone and buprenorphine. So with buprenorphine, it's actually a medication that gets absorbed by the big vein in your mouth that's under your tongue. So it does not, very little medication gets into the breast milk. And if it is in the breast milk at very low doses, in order for the baby to absorb it, they would have to be holding the breast milk in their mouth. And we know that babies generally don't do that because the naloxone is destroyed in the gut. So they really don't get any negative exposure. And the bioavailability of buprenorphine in the stomach is very, very limited. So that's probably more information than you need, but we encourage women to breastfeed. It is good for bonding. Breast milk has incredible protective effects for the baby long-term, and that skin-to-skin contact can help with any neonatal abstinence symptoms that the baby may be having if they were exposed in utero. So just a little bit about our program. So we have the privilege of having an integrated program, which is which means that our prescriber is actually a nurse midwife, which is fantastic. So she gets to like answer all the baby questions and all the postpartum questions and delivery questions, as well as prescribe medication for opioid use disorder if that's indicated. And so you guys may be familiar with, we have people come in weekly for a group until they have 90 days of sobriety. We do drug screens, which can be observed, strip counts. So it's a pretty rigorous program with a lot of accountability and oversight. We also have a peer recovery support specialist in our group and encourage people to go to peer recovery support meetings. And I don't know if people have heard about, we have the ACE program, which is all women who deliver at Ruby, and actually some hospitals around the state can be referred to this program where they get this additional support of peer recovery support, a social worker available for counseling, and referral to all kinds of services like birth to 3 and things like that. So this is, there's 17 sites around the state, which help support women with substance use disorders. So just wanted to say a little bit about relapse. Oftentimes, relapse is seen as a failure and an indication that patients are not interested in sobriety or recovery, which is actually not true. And it's seen as like kind of a binary thing, like people are either sober or not sober. And if you're not sober, it's all over. But it's really a process. So relapse is preceded by changes in thinking, behavior, attitude, and mood. And if we're attuned to some of those changes, we can help patients become aware of them, because sometimes they're not, and see them as warning signs instead of assuming that the person has relapse, because often those things will happen first and then the relapse can occur. So there's some myths about relapse being abstinence from substances means I'm in recovery. It does not mean you're in recovery. It just means you're not using. And oftentimes when people just don't use substances and don't make any other changes, they're pretty miserable. So that's why we encourage people to make behavioral and thinking changes and improve social connection. Another myth is that people who relapse don't have willpower. Again, we know this isn't really about willpower. It's a brain disease, and so it takes time for people's brains to heal. Motivation is an important factor in recovery, which is different than like willpower. The third myth is a person always knows when they were in the process of relapse, and often people will be like, everything was going fine, and then all of a sudden I relapsed and I don't know what happened. So one of the things we do in treatment is we teach people about the relapse process. And then the myth that we hear most often is that when a person relapses, that means they do not want to be sober. And that's absolutely not the case. It means they do not yet have the tools to do that. And that includes living in a sober environment. So if somebody is trying to be sober and not use substances, and they are surrounded by other people who use substances, that's really a setup for failure. So we try and help people change their physical environment as well as their thinking. So some truths about relapse. We really treat relapse or recurrence as a learning experience. What did you learn from it? What would you do differently next time? It's like a rich learning experience. We try not to be shaming and help them develop skills based on that experience. Cross-addiction can cause relapse, so that is a truth. So if people are using other substances, including alcohol, marijuana, we have an abstinence-based program in that respect, because using other substances can kind of lead people back to either their substance of choice or develop a problem with a new substance. Awareness of triggers can reduce associated relapse, so we work on that in treatment. And then treatment of co-occurring mental health disorders can also decrease the risk of relapse or recurrence. So we try and do that as well with both medication and therapy, because as I started out saying at the beginning, the rates of trauma and sexual and physical abuse for this population are very, very high, and oftentimes whether it be flashbacks or triggers can lead to recurrence, because that's how they manage their symptoms. So just in kind of wrapping up, how do we help people? I think the most important thing is conveying compassion. Now, sometimes it's really hard to convey compassion with someone who is angry or not doing what we're asking them to do or struggling. And so recognizing our own biases can be part of making it a little bit easier to convey compassion to people, and also taking care of ourselves, which I know Child Protective Services workers, managers, supervisors is really hard, because you guys are understaffed and have too much to do. Using non-stigmatizing language not only conveys a message to patients that we are being non-stigmatizing, but there's been research to show that it actually changes the way we think about that individual if we call them an addict versus we call them a person with a substance use disorder. And then really understanding that intersection between trauma and addiction can help with having compassion and recognizing addiction as a chronic disease versus a moral failure or a lack of willpower. So this is a good resource if people are interested. Can be accessed online as a PDF, and it's free, has lots and lots of information about treatment of pregnant women and parenting women with opioid use disorder. And Amanda and I have both done some trainings around the country trying to deliver some of this information to folks. But it's free and it's online. And then I have some resources. I think this will be sent out to everyone after the talk today. But any questions kind of right off the bat, or thoughts about your experiences with pregnant women with substance use disorders?
Hey, Laura, could you explain a little bit about like the blocking mechanism?
So naloxone. So naloxone was added to buprenorphine to prevent misuse. So misuse being injecting or snorting. And so that's when it gets activated. So if people are not injecting or snorting, it doesn't get activated. And so sometimes people misunderstand that, and they say that the medication has the blocker. So the naloxone is really the blocker, but it's kind of not doing anything if you're not misusing. And so the buprenorphine itself, if people use on top of that an opioid, it does help sort of protect people from overdose risk and protect people from euphoric effects of opioids, because it has this ceiling effect. It's actually a really cool medication because it stops like having increased effect at a certain level. And often when we start people on medication, one of the signs that it's too much is that they don't feel well. And when you back it down, they're like, oh, well, that's much better. And so we try and hit it right so that people feel normal. People should not look intoxicated. If you have someone who looks intoxicated on buprenorphine, there's something else going on. It means they're using something else, or they're not taking it as prescribed. Good question.
Is that the reason why a lot of times when we look at the drug testing results, the naloxone is higher, the quantity in the specimen is higher than the buprenorphine?
So they get metabolized differently, and actually individuals metabolize them differently. We know from studies that some people are very fast metabolizers of this medication, and that can be problematic, and other people are not. So different people's results can look quite different. So it's a little bit hard to figure out what's going on there because people metabolize it a little bit differently.
So does metabolism have anything to do with the idea that you were talking about, that if they're not using it improperly, then it doesn't get absorbed? You know what I mean? Am I making that, is that clear? Ish?
Yeah, so we try and, I mean, if somebody's on too much, we try and like back it down, right?
Yeah.
And so there shouldn't be, yeah, it's a little bit hard to tell from those confirmatory urines, but
Okay.
what kind of concerns do you see, Tina, when you look at those?
Nothing really. It was just like I vaguely remember once upon a time when I started with COAT, they were like, yeah, most generally we always see that the naloxone information quantity is higher than the buprenorphine, and I guess I didn't know why.
Mm-hmm.
Just I always, when I was looking at their screen results, I'd be like, okay, well, it's higher, that means it's good.
Yeah, and we want it to be in there. So
yeah, right. It needs to be in there at least. But I guess I never really thought to ask why until I heard you bring that up, that it was in there as the blocker, but unless you were using it improperly, you wouldn't really see a big difference. So thank you for that.
Sure.
I have a question for you, Laura. So I guess for context for everybody, I do, as a clinical forensic psychologist, I do a lot of parental fitness evaluations. And so I'm often seeing this parent who has a substance use disorder, and they're questioning whether they have that minimum adequate level of parenting. So what I'm seeing a lot are families who are going to Pittsburgh, paying $250 a month out of pocket, getting their Suboxone, going home, coming back next month or the month after. And so in my head, I'm like, oh man, they should be at a coat clinic. Why are they not doing this? So I guess it's twofold. Do we know how can that be effective just to do that medication component of MAT, medication assisted treatment without the therapy? How effective is that? And then the second question, I guess, is there a place online or somewhere that would have a resource of all of the kind of more comprehensive programs for these types of treatment?
So I'll take the first question and then I'll throw the second question out to the group. So it's interesting that the research has shown that medication alone can be effective. I would argue that depends on the patient and their need. So oftentimes we have patients who do not have stable housing, are financially very insecure, food insecurity, safety issues, history of trauma. So those guys have a lot of needs where medication is not going to help you with your housing issues, or, medication for opioid use disorder is not really going to help you work through your PTSD. For some people, yes. For most people that we see, now I have a biased sample because most of the people that come to us have pretty severe opioid use disorder. I would say no, but the research that's out there is that medication alone can work for people.
So in giving a recommendation, it would be appropriate to say, continue what they're doing if they could get into a comprehensive program that likely would be more helpful. But this is also not.
And in the parental fitness, I don't know if you assess other needs that they may have that are
There's
not
always lots of other needs.
Yeah, that are not being met and could be met in a more comprehensive program. And so that may be a way to address it. That, one of the things that patients always tell us is like, you hold us accountable. That is the most important thing for me. Like, that's what they say. And so we know that accountability is like a key recovery tool. No, it's not, we don't have to be the people, like if they have other people in their lives holding them accountable, like their partner or their mother or their kids or whoever. But oftentimes it's really the treatment program because they don't have other people in their lives holding them accountable. So that's why some of those programs are not great, because there isn't a lot of accountability. The other thing we know that helps people in recovery is feeling connected and feeling cared about. And patients will frequently tell us, we know that you care, versus I go up, I see this guy for 5 minutes. He doesn't even really know who I am. And I leave and I pay him $250. Like, they don't feel cared about. They don't feel necessarily like that's treatment. They're being given a script. Now, not all providers do that, but that's often some of the description that we get from where they're paying cash for that visit.
Yeah, I second that. I tell patients that, again, some of those clinics may be a great fit for some of them, but I would question a place that's not willing to take insurance and is only willing to accept cash. Then the concern is there may be some other things that they're really not providing with great care. So I appreciate everything that Laura said about that. Colin, you asked a great question. I do believe we have a COE website somewhere that has all of our West Virginia hub and spoke locations that we have partnered with that sort of operate with the West Virginia COAT model. And so my homework is that I'm going to track that down and get that out to this group, because that will be, that's really a thing that's needed across the state. So that's going to be my homework to get that to you all.
And then Shatterproof was supposed to be that. I don't know if it has been that.
But yeah, great question, Laura. There was an organization that partnered in a handful of states to try to get an updated database on programs. Programs had to participate with them to really get accurate information, and some places don't. But that could be one place to start too. Also, oh my gosh, Help for West Virginia has a database that includes both inpatient and outpatient services and other things as well. So, and I do believe they're an up-to-date database.
Yeah, so when Elizabeth and Mitra send out the follow-up, we can maybe look up Shatterproof and Help for West Virginia and include
Yep.
those links.
I will do that.
Thank you.
Yeah, for sure. Share it and we'll get it over, and
Yes,
Jay,
I will-
myself, or Mitra will get it to you
I
guys.
will get that to both of you guys.
So Rick or April, any questions based on what you guys see on a regular basis? Or thoughts?
I'll just say that with my clients that are in like the COAT program seem to be much more successful than the clients that are going to Pittsburgh or to cross state lines and just get the prescription, because they are getting the therapy and conquering their root problem versus just getting the medicine.
Mhm.
That's
As
just
an-
my insight as a CPS worker.
As an evaluator, the other thing that's coming up more now is medical marijuana cards. And because you can get it for PTSD, and so they claim, but I am treating my PTSD. And so I've been drawing a line that I don't think that is very helpful for people, but I want to make sure that that's an accurate statement to be making from a provider's perspective.
Yeah, April and Rick, do you guys allow people to have a medical marijuana card? Who are involved with CPS?
This is a really big controversy right now with our court system and our judge. I have several clients that have medical marijuana cards. Generally, they are from a doctor in like New York or Los Angeles, California, one of these telehealth places where they just pay and get it. I had one of my clients tell me he was diagnosed, he was taking it for PTSD, but he didn't even know he had PTSD. That was what the doctor had diagnosed him with. So our court system really looks at that, looks at where the prescriber's from. They have to provide receipts where they've gotten it from the dispensary. There's like some checks and balances that they're trying to put in place, but it's a hot topic right now.
Yeah,
I
just
I
so
think the
you-
court
Some
always
judges
takes
do,
it
but-
more seriously if it's, other treatment other than just the medication. I think that they're very suspicious. I think all of our, judges have been very suspicious of the ones who go to Pittsburgh and other places.
And for the medical marijuana card, does that vary like county to county how that's handled? Like, is it different?
Well, we have different judges, so they
So-
deal with things in
Okay.
their own fashion, and it's kind of court driven how we respond to those things.
I just wanted to circle back around and say, April, I really appreciated your comment. You said that so eloquently about, when they're getting the right kind of treatment, what they're really doing is getting at and getting treatment for the root problem. And to me, that's sort of exactly why we're having the sessions. And I just love that you were able to capture that.
Yeah, I love that. I love that piece too. And I think that another in any treatment program, I think another thing that treatment programs provide is that support network too. And so, when Laura, I love the slides of the myths of relapse and the truths of relapse. And, I think of our patients and how educational relapse can be and how supportive those groups are. And I just think of those like cash and carry places. And I think like, what if you have a relapse? Like how I could never, like some of the ways our patients process relapses, like that would never happen there. And who are you processing that with? And hopefully you did, gain a better support system where you could process that, but it always provides that network and building healthy relationships there. So I think that's a benefit of treatment too.
And they see each other's successes and consequences. So, sometimes CPS intervention is a consequence, or not progressing in the process of reunification is a consequence. And when we do group-based care, they can really see that and be like, I want that to be my journey. Like they see someone increase their visits or like move back into the home with the parents who have the kids and get reunification sort of in that way, or they see people decrease their visits and go in a different direction. And so it's I think really beneficial to have that connection. They also give each other all kinds of hope and suggestions and recommendations of how to work with the systems that they're interacting with.
I think oftentimes too, there's something else that I've seen, working the front lines is our mothers that are using or anybody in the family, their support system, their familiar support system is very limited. Sometimes that's the cause of their trauma. So they don't have, they're not in their environment to have support and do well. And if they do these COPE programs and do therapy in group, that just adds to their tool or toolbox to have somebody else to share experiences with.
Absolutely. Absolutely, we see that. I'm glad you see it too. Or they're sharing that obviously with you, so that's how you see it. Yeah. Do you guys have any questions specific to, I know so often there are questions about medication for opioid use disorder and concerns that this is not helpful, or any questions or thoughts about that?
You can also place in the chat and really appreciate it. But in the interest of time, I think we should move to the case if that's okay with everyone. And if you do have any questions in the meantime, please do include them in the chat. Amanda, did you want me to share my screen, or did you, I made you a co-host as well. So whatever you're comfortable with.
You could totally share I know I usually take control of this, but you can share your screen today. So the case I chose today, and typically, we're presenting cases that we can put out there and discuss and talk and kind of gather ideas about, and absolutely up for that with this one. But I kind of chose more of a success case to kind of highlight some of the pieces that Laura really pointed out, because, and I mean, I could be biased, but I totally love this case too. So I like pointing out some of that. So this was a case, this patient is a 30-year-old female, was referred, struggled with substance use disorder pretty much all of her life, very long time. And a referral to CPS occurred when she overdosed in front of her oldest child. She was pregnant at the time and her oldest child was 9. So her child was removed. And once she had the baby was placed as well. But she actively participated in her MDTs. She worked hard towards reunification. She did end up getting both children back. But it was quite a process. And as we're talking about treatment and the pieces of treatment, she really worked treatment. And there were times she didn't work treatment. There were times that she relapsed and she struggled. And she struggled for, she never really went back to active addiction, but there were times that when she relapsed, she was really struggling with some pieces. And I feel like they were all learning events. She really identified, I think at one point, I remember one relapse, she was doing really great and, just kind of felt that she was strong enough now to be around some of her closer friends and family members, but identified quickly that was not healthy for her because it ended up leading to a relapse. And sometimes some of those positions that she was placed in, it was just kind of put in her face and she was not strong enough. And I feel like that's something that some of our patients struggle with. They feel like it's a failure when they're not strong enough, but not realizing that, it's really hard. It's a lifelong disease that you have to work at every day and work hard at it. And so she was really accepting of that and helped with that. But she brought it to group. Again, she had those supports. She processed with her supports. And And she actually, in turn, from some of these learning experiences, has become a great support for other group members. And so I feel like those relapses were so significant in her progress in treatment that it not only helped her, but it's helping others too. So when others feel like a failure like that, she is absolutely one that supports and helps them move forward. She was involved with a lot of, the children were in foster care, so she was involved with that. She was involved with our ACEs program. So like Laura mentioned, that's through WVU OB care and across the state. And the ACEs is the Assist, Connect, and Encourage. So really assisting. And the ACEs program, our peer recovery coach has a group of her own. And so this patient really identifies like that to be one of her biggest supports, right? So was a treatment as an MAT treatment, her groups that she participated in, NA, AA, and any other groups that she participated in. And then one of the other pieces that she identified to be really helpful is sober outings. And so, I don't think we always think about that, but a lot of our patients, when you think about going floating or going to a picnic or going to a concert, a lot of the times there's alcohol involved with that, right? And for many of our patients, alcohol leads to other substances. And so they know they have to stay away from alcohol. And so finding sober outings can be really difficult when you're in recovery. And so she identified how finding those sober outings, like I said, going floating, picnics, concerts, like they have a lot of those sober outings. And so she identified participating in those were great. It was great for her family, getting her family back involved with the community, getting her and her husband back involved with the community in a sober way, and teaching them to have fun in these instances in a sober way. Like that was huge for them. And I don't think we always take that into consideration, but she's a strong advocate for that. But she's done great. She came to us from residential, and she was on buprenorphine, continued that in outpatient. She began the Sublocade shot about 8 months ago. And she's discontinued Sublocade. Like she's slowly discontinued Sublocade, but she continues to come to treatment. So she's not on any medication. She comes for therapy and the group involvement. She's pretty amazing leader when it comes to that, and peer as well. She has struggled in getting her children back again, finding some of those sober events that she can re-engage her children with. And then another thing that she struggled with, and she was very verbal from the beginning, was when she was when the reunification with her children had taken place. She struggled with the stress of having 2 children after not having them for an entire year. So she talked about how stressful it is and how fearful she was that it was going to influence her recovery. And she was almost embarrassed of that. And we see that a lot with our patients, the fear of having their children removed again, because they're not sure how they can handle them. And then, really sharing that with others and not knowing how to kind of meet those needs. And she was open and honest about it from the beginning. She got a lot of support from the group. She got into resources that could help her in managing her stress and her, the stress of parenting. So that was really helpful for her. But not many patients are open and honest from the beginning, but she totally was. And I think that really benefited her. So she, like I said, she worked every program there was.
And I think, Amanda, you and I have talked about collaborating with CPS. If you guys identify, hey, this reunification process is likely to be a challenge, we have resources at behavioral medicine that can support that transition. And so we encourage you guys to reach out to us, because a lot of those programs.
Yeah, absolutely. And this patient just reached out to me with concerns about her child, who is now 5, but she's concerned about some of the behaviors, and so she's able to link and want to work and get that taken care of. And so it continues, and you're right, Laura. So that's one of the gaps that actually Anna has been a strong advocate with, and identifying, and we talked about her services overlapping. a little bit longer than when reunification occurs, just to help kind of loop our patients into some of those resources so that they feel supported and they don't feel like overwhelmed or feel like they're a bad parent because they're getting too overwhelmed and stressed,
Yeah.
just like every parent does.
I know we're at the hour, so Rick and April, that was just sort of an example of what a case looks like. You don't have to fill all that stuff in, but we do encourage like case presentation as we move forward in our curriculum.
Absolutely. Thank you guys so very much. I really appreciate it. We are at the hour. Just the only announcement is the next time you guys will meet will be on March 15th for trauma in children. But if you have any questions in the meantime, please just pass them our way and we will get an answer for you.
Thanks, everyone.
Thank you, everyone.
Bye, everyone.
Bye.
Thanks, everyone.